Good morning. Group 2 will discuss ethical considerations in end-of-life care. We are Dr. Mark Hosaka, Dr. Teresa Chen, Dr. Kay Jimenez, and Dr. Ronald Santos. Our topic outline would be to introduce end-of-life care, ethical principles and issues to consider in end-of-life care, ethical dilemmas in end-of-life care. Next will be goals of care for the terminally ill patient, and we will present a case scenario for ethical dilemmas. We will also critique in the responses and practices in end-of-life practice and give recommendations for progress and improvement. And lastly, we will make our conclusion. All human beings are mortals and death is inevitable. End-of-life care refers to health care for a person nearing the end of their life or in the advanced stage of a terminal illness. Advancement in medical technology are changing the norms of natural death. Technologically advanced treatments are capable to intervene at the time of death and prolong the lives of people. Medical advancement hold no promises for recovery. They can sustain life with or without meaningful existence or with secondary support. Decision-making for end-of-life care can prolong human life with the support of medical technologies or can let the natural death process continue by foregoing the treatment option. What are the ethical principles to consider? First is autonomy, the right of patients to make decisions about their medical care without being influenced by their medical care provider. Beneficence, the obligation of the physician to act for the benefit of the patient. Non-maleficence, the obligation of the physician not to harm the patient. Another is distributive justice, the fair and just distribution of benefits and burdens among society's members. For virtue ethics, it's the quest to understand and live a life of moral character. And deontology, the theory that suggests actions are good or bad according to a clear set of rules, duties, or obligations. Ethical issues surrounding end-of-life care. The philosophical underpinning for autonomy, as interpreted by Immanuel Kant and John Stuart Mill, and accepted as an ethical principle, is that all persons have intrinsic and unconditional worth, and therefore should have the power to make rational decisions and moral choices. Each person should be allowed to exercise his or her capacity for self-determination. Respecting the person's right of autonomy facilitates the exercise for self-determination for their end-of-life treatment choices. The physician's work is rooted in the deontological theory or the performance of duty. The principle of beneficence is the obligation of the physician to perform duties to the greatest good for the patient and supports a number of moral rules to protect and defend the rights of others, prevent harm, and remove conditions that will cause harm. It is the obligation of the physician to act for the benefit of the patient. Non-maleficence is the obligation of a physician not to harm the patient. This simply stated principle supports several moral rules. Do not kill, do not cause pain or suffering, do not incapacitate, do not cause offense, and do not deprive others of the goods of life. The practical application of non-maleficence is for the physician to weigh the benefits against burdens of all interventions and treatments, to eschew those that are inappropriately burdensome, and to choose the best course of action for the patient. The core of professionalism is a therapeutic relationship built on competent and compassionate care by a physician that meets the expectation and benefits a patient. In this relationship, which is rooted in the ethical principles of beneficence and non-maleficence, the physician fulfills the following obligations: cure of disease when possible, maintenance or improvement of functional status and quality of life, relief of symptoms and suffering, promotion of health and prevention of disease, prevention of untimely death, education and counseling of patients regarding condition and prognosis, avoidance of harm to the patient in the course of care, and providing relief and support near time of death or end-of-life care. Of the several categories of justice, the one that is most pertinent to clinical ethics is distributive justice. Distributive justice refers to the fair, equitable, and appropriate treatment distribution of healthcare resources determined by justified norms that structure the terms of social cooperation. An advance directive enables competent individuals to design and document their healthcare decision plan in advance in case of future disability or terminal illness. This can give the patient an individual autonomy so as to receive end-of-life care consistent with their preference. In case of a competent individual, he or she can convey or document their end-of-life treatment preferences autonomously to the authorities on admission, or can take a consensus autonomous decision after getting end-of-life care information from the healthcare providers. On the other hand, in case of incapacitated individuals, families play a central role as proxies or primary caregivers. Families have a responsibility of putting forth the end-of-life care preference of the patient. For virtue ethics, honesty and truth-telling are vital components in a physician-patient relationship. Without this component, the physician loses the trust of the patient. An autonomous patient has not only the right to know or disclosure of his or her diagnosis and prognosis, but also has the option to forego disclosure. Another virtue, compassion, is an emotional response to the suffering of others. Once felt, it entails subsequent action to ameliorate their suffering. Recently, compassion has become the flagship concept to be fostered in the delivery of end-of-life care and the rallying call for social action and public health intervention. Ethical dilemmas surrounding end-of-life care. Ethical dilemmas are conflicts between principles. Each one of the four principles of ethics is to be taken as a prima facie obligation that must be fulfilled, unless it conflicts in a specific instance with another principle. When faced with such a conflict, the physician has to determine the actual obligation to the patient by examining the respective weights of the competing prima facie obligations based on both content and context. Ethical dilemmas in end-of-life care are physician's duty to preserve life, beneficence versus withholding treatment, non-maleficence. Physician's duty, deontology versus unnecessary use of limited medical resources, distributive justice. Physician's obligation, beneficence versus patient's autonomy. Life-sustaining treatment, beneficence versus providing quality of life. Patient's advance directive, autonomy of decision versus proxy decisions, family preference. Goals of care for the terminally ill patients. First, to respect patient's end-of-life care decision or patient autonomy. Optimization of quality of life until death, alleviation of suffering or provision of comfort care, and granting the wishes of the family, being the primary caregivers or the proxy decision.
We will present a case scenario to further illustrate the different ethical issues in end-of-life care. So we have a 60-year-old businessman, father and husband, who was rushed to the hospital and immediately intubated due to poor sensorium because of a massive intracranial hemorrhage secondary to ruptured aneurysm. He underwent clipping of the aneurysm and ventriculostomy. Presently, he is comatose, vital signs are stable. The doctors are expressing guarded prognosis, considering the massive intracranial bleed and clinical status. Their disposition was to monitor the patient in the next few days to wait and see. A family conference was called to resolve issues among the physicians and close members of the family, including the wife, children, parents, and siblings of the patient. The eldest son has presented an advance directive by the father in writing 10 years ago to withhold any form of medical treatment to prolong his life if he will only suffer and have poor quality of life. The wife no longer consents to aggressive treatment. However, the parents and other siblings would like to continue aggressive management. To come up with an ethical decision in this type of clinical case, we will be utilizing the Angeles model for ethical reasoning. For the facts of the case, we are presented with 60-year-old male, comatose on ventilator with guarded prognosis, written advance directive by the patient himself 10 years ago to withhold any form of medical treatment to prolong his life if he will only suffer and have poor quality of life. The wife no longer consents to aggressive treatment. However, the parents and other siblings would like to continue aggressive management. So the following are the stakeholders, its interests, and relative power over the decision. The patient is the one who must decide. However, he is comatose, which makes him powerless over the decision. The relatives are the proxy to give decisions and has the full power to decide. The doctors, being the main healthcare giver, explains the prognosis, outcome, and the possible management, and they have the power to execute the plan of management after getting a consent. The following are the conflicting values in this case scenario. Patient's advance directive / autonomy of decision versus proxy decision. Beneficence in futile treatment versus ventilatory support only. Aggressive treatment versus pulling the plug. Physician's duty to preserve life versus comfort care, and beneficence to patient versus inequity. For further identification of the dilemma of conflicting ethical principles and values, we must understand fully of the case scenario. Under beneficence and maleficence, we now know that the nature of the illness is irreversible, prolonged suffering, and quality of life not guaranteed. The goals of treatment for this patient is neurologic improvement, and the treatment options are ventilatory support and life-sustaining treatments. However, the prognosis of the patient is poor. Under the respect for autonomy, this involves the patient's rights and preferences. Is there any informed consent? None. Is the patient mentally competent? No. If the patient is mentally incompetent, are patient's prior preferences known? Yes, because he has advanced directive given 10 years ago. Under the beneficence, non-maleficence, and respect for autonomy, which involves the quality of life, the expected quality of life of this patient is very poor. The deficits with or without treatment, the patient is comatose and can lead to worsening condition, then mortality. Then who decides for the quality of life? The family and the physician. And the rationale to forego life-sustaining treatment is the advance directive, poor quality of life, and family wishes. Under the distributive justice, which involves the external forces and context, are there any conflicts of interest? No conflicts in physician, wife, son, or patient's autonomous decision to withhold aggressive measures. However, there are conflicts with patients, parents, and siblings. Are there any conflicts of interest based on religious beliefs? None. How about legal issues? Patient's advance directive and wife's and son's wishes versus the patient's parents and siblings' wishes. Are there any conflicts of interest between third parties? None. And how about the problems in allocation of resources? Yes, the prolonged intensive care with ventilatory support with utility purpose, other patients are denied of limited ICU beds and ventilators. So this slide will show us the different alternatives, the values upheld, the values contradicted, and the consequences of these alternatives. First alternative is to continue all aggressive measures. So the values upheld was beneficence, but the values contradicted are quality of life, distributive justice, and economy. And the consequences of that alternative are the following: prolonged life support, economic burden not for family, against patients and wives and sons' wishes, misallocation of limited resources. If the alternative is pulling the plug, these are the following values upheld: respect for patient autonomy, advance directive, distributive justice, quality of life, and economy. And the values contradicted are beneficence, parents, and siblings' wishes. And the consequence of that, the family will pull the plug with possible regrets about moral obligation to patient. There will be family conflict regarding pulling the plug, parents and siblings not amenable, hospital needs to intervene and resolve family conflict to avoid legal issues, and there's no additional economic burden. Doing the third alternative, which is the continuation of ventilatory support, but no aggressive measures and signing of DNR status, there are many values upheld. They are beneficence, non-maleficence, respect for patient autonomy, quality of life, economy, distributive justice, honoring wife and son's wishes. And there are no values contradicted. And the consequences, middle ground for patients' benefit, family wishes, and doctors' obligations. And there are no lesser economic burden for family. So what should be the decision? It is clear that the underlying cause of ventilator dependence is irreversible. Continued ventilatory support will not provide meaningful quality of life for the patient and may prolong suffering. It is essential to involve the family in the decision for end-of-life care for this patient. And continued ventilatory support with no aggressive measures is the middle ground for patients' benefit, family wishes, and doctors' obligations. It provides time for family acceptance and resolution of personal and family issues. The physician can prepare the family for the inevitable. There are no moral obligations violated versus pulling the plug. It offers lesser economic burden for the family, and the allocation of resources can be considered appropriate and distributive justice is upheld. So what should be the course of action? Ensure that family members are present when the final decision is made. We should request for anointing, religious rites, family visits. This should be honored. All other life-sustaining treatments like artificial nutrition, hydration, antibiotics, dialysis should be discontinued. The patient is maintained on ventilatory support. All unnecessary medical contraptions should be discontinued. Ensure that the patient appears comfortable. Physician must be available for questions and additional concerns, and healthcare givers must demonstrate empathy and compassion throughout the dying process. So let's now go to the critique of the responses and practices of end-of-life care. There are ethical and legal issues surrounding the question of who decides patients' mental competence and incapacity to give advanced directives, and whether or not families' moral interests can be used to put forth the end-of-life care for the patient. The stewardship of limiting medical care is surrounded by ethical issues, as the patient and their families do not understand the need to limit treatment in some cases where it is futile. There is still a gray zone on the decision of who will turn off the respirator from the patient. Is it the relatives or the healthcare providers? Either doesn't want to do it because of the guilt feeling of terminating patient's life. Autonomy gives the patient a right to control his treatment according to his preferences, but many times their preference is inconsistent with the end-of-life care they receive. Physicians are strongly influenced by the patient's or family's wishes and do not consider the benefits, drawbacks, and limitations of preferred treatment options. So these are our recommendations for progress and improvement. First, healthcare organizations can work towards developing and implementing guidelines and policies for end-of-life care decision making, especially policies for withholding or withdrawing the treatment options, so as to avoid the ethical dilemmas. Second, there should be proper disclosure mentioning the limitations of certain specific treatment options. Third, healthcare executives can develop resources supporting palliative treatment care choices. Fourth, the appointing an interdisciplinary ethics committee and employee assistance facility to address any ethical crisis. And last, a well-formed and integrated ethics committee can safeguard organizations' future by increasing patient satisfaction, increasing organizations' productivity, avoiding unethical activities, restricting undue costs, and reducing the risk of lawsuits. In conclusion, the end-of-life care refers to health care for a person nearing the end of their life or in the advanced stage of a terminal illness. Technologically advanced treatments are capable to intervene at the time of death and prolong the lives of people. Autonomy, beneficence, non-maleficence, distributive justice, virtue ethics are the ethical principles surrounding end-of-life care. We have presented a clinical scenario in end-of-life care and how to make an ethical decision. There are still several ethical dilemmas concerning end-of-life care management, and recommendations for improvement were cited. So again, this is Group 2, composed of Dr. Marco Saka, Ms. Teresa Chen, Dr. Kay Jimenez, and yours truly, Dr. Ronald Santos, who have presented the ethical considerations in end-of-life care. Thank you and have a good day.